Hi, I'm Geoff Walker. Now it's my pleasure to introduce Dr. Ben Benjamin. Dr. Benjamin holds a PhD in sports medicine and education and is a well-known, respected educator, author, and practitioner in the massage and bodywork field. He's the author of these 4 books, widely used in the field as well as his popular regular column in several therapy publications since 1986. Dr. Benjamin founded his school, the Muscular Therapy Institute, in 1974 and has been in private practice for more than 45 years. He travels throughout internationally teaching orthopedic massage as well as Aaron Mattis's active isolated stretching. He's also created a series of DVD programs on the assessment and treatment of the low back, the neck, the knee, and various common injuries. Now, let me hand you over to Dr. Benjamin.
Thank you, Geoff. I'm really glad to be here. Glad to be in Australia, and I look forward to coming to Australia, to Sydney, to teach in March. Let me give you just a few other little tips to the audience here. You've got an orange white arrow in the upper left-hand corner of your control panel, and you can click that. Why don't you try clicking that, and that will disappear so that you can see the whole screen. And if you click it again, it will come back. And you've got a little questions tab down there that if you click the little asterisk or plus sign, it will open up. And if you want to ask a question at any time, if you got a question for me, Geoff is going to kind of collect them and ask me at the end of the presentation. So why don't you see if you can open up that tab and just say hi, hello, or whatever you say in Australia when you greet somebody, so that we know that you figured out how to use that. I'll just give you a second to do that. There we go. Good day. That's a G-D-A-Y. Okay, I've never seen that. Okay, that's great. Okay. Okay, great. All right. Terrific. All right, so let's begin our webinar adventure here. And here's some things I'd like you to keep in mind. Think about what's the difference between a direct and indirect cause of pain, and what's the message behind a muscle spasm? What does that mean? Which structures in the neck cause the most chronic pain? And what's the precise definition of referred pain? This is just a few things that we'll be covering, among others, that you might just keep in mind. So as Mark Twain famously said, to a man with a hammer, everything looks like a nail. You may have heard something like that in your lifetime. And in the context of health concerns, this means that the tools that are most easily available to us, including our theories, our assumptions, the testing procedures we do, and our technical skills, have a tremendous impact on the type of care that we choose to provide. Now, health professionals in different fields offer dramatically different assessments and treatments for the same condition. For instance, in the case of pain and injury, we would expect chiropractors to address spinal misalignments, acupuncturists to emphasize the flow of energy or qi, and surgeons to consider surgical options. Now, within the massage and bodywork field, the focus has typically been on the muscles. Now, over the past few decades, many health professionals have begun to seek therapeutic alternatives outside their traditional modes of practice. Physicians are working more in collaboration with chiropractors and referring more and more of their patients to massage therapists and acupuncturists. Chiropractors are broadening their areas of expertise and learning how to work with a wide variety of soft tissue injuries. I don't know if you have Graston technique down there, but a whole special technique with special tools. Massage therapists, too, have been integrating new knowledge and skills into their work by studying other bodywork modalities, as well as personal training and fitness. Now, some of these changes, excuse me, including an increasing reliance on the principles of orthopedic massage, have allowed practitioners to dramatically increase their effectiveness. Orthopedic massage refers to the precise techniques for assessing, understanding, and treating musculoskeletal pain and injury. Using orthopedic testing procedures, we can more clearly identify what structure or structures have been injured so that treatment may be targeted to those particular tissues. Now, we can also determine what treatment methods will be most effective for each individual, if we know exactly what's going on. In addition to hands-on therapy, we may perform specific stretches on the client or recommend exercises for the client. Now, my study of orthopedic medicine began over 30 years ago and was really transformed. My whole practice was transformed, and my teaching, leading to much greater success in my treatment and my ability to figure out what's wrong with people. And in this webinar, I'll use the principles of orthopedic medicine and orthopedic massage to correct 7 misconceptions that are prevalent in our profession. I studied with orthopedic medicine with Dr. James Syriacs from London and with Dr. Milne Angley starting about 29 to 30 years ago. And I was very fortunate to work with Syriacs while he was still alive. So let's go to the misconceptions that are out there and see if we can correct some of them. And there are many others. I just picked 7 that seem very prevalent to me. Most chronic pain and injury is caused by excessive muscle tension. Now, I know I believed that for a long time. Matter of fact, I wrote a whole book about it. And when I began my career, I thought that, most of the long-term pain in the body was indeed caused by chronic muscle tension in the body. I gave talks about it. I wrote a book about it. Are You Tense? This book up here. What I didn't know at that time was that muscle tension was only one piece of the puzzle of chronic pain, but really not the main protagonist. Now, even today, massage therapists spend a large portion of their training learning about muscles. Therefore, when something goes wrong in the body, muscles are often the first place that they look. Now, when a client is in pain, the practitioner might attribute that discomfort either to a muscle spasm or an injury to muscle tissue. However, as we'll see, this is very, very often not the case. First, let's look at muscle spasms, which are frequently identified as the source of pain, not only by massage practitioners, but by all sorts of healthcare practitioners. In most cases, muscular spasms are the result of an injury of some other tissue, not the cause. Muscle spasms function as a protective mechanism to help you avoid further damage and further injury. For example, if a ligament or a nerve root in your low back is injured, or your neck on one side, your body is going to work to prevent you from performing movements that put more stress on those structures, causing further damage. So as you start to move, for instance, your neck or your back, in a way that exacerbates the injury, your muscles, the low back muscles, the neck muscles, will go into spasm to prevent you from doing it. And that's a good thing, because it's protecting you and helping you. Now, although muscle strains and micro tears occur frequently, muscles are highly vascularized and therefore heal pretty quickly. Now, this is unlikely to cause long-lasting serious pain. Where there is ample circulation, there's a more efficient and effective healing capacity. Now, in contrast, joints, tendons, ligaments, they have a very limited blood supply. And so without proper healing, they heal really, really slowly, if at all. So here we have some ligament structures, joint structures here, muscles. The muscles are red. They've got a lot of blood circulation. All that other stuff heals really slowly. Now, if you look at a fresh cadaver, or even the muscle chart here, you can't help but notice that, muscles are red. And the ligaments and tendons are whitish in color, sometimes slightly gray. And this is because there's extensive blood circulation in the muscles and barely any circulation in the ligaments and the tendons. The internal structures of the joints, once you dissect them, they're also pretty white. And if any of you get a chance to do some dissection, it's really quite quite an amazing revelation to understand how to treat the body, what things really look like, feel like inside, where the fascia is, etc. I strongly recommend it. So tendons and ligaments are frequently injured structures, and they're a major cause of chronic musculoskeletal pain. Now, joints are also a common source of pain, with joint damage occurring much more frequently as we age. Now, finally, injuries to the fascia also occur in chronic pain in many, many different parts of the body because, as you know, fascia is intimately involved with every other tissue in the body, covering just about everything from our cells to our heart. The structures most vulnerable to injury vary depending on the part of the body that happens to be injured. So, for example, in the thigh, it's generally the muscles that are affected if there's an injury. If you have a pain in the middle of your thigh, it might be the hamstrings or the adductors. These are common structures that get injured where they originate in the thigh. Now, in the shoulder, if the client is under 40, it's generally one or more of the rotator cuff tendons that get injured, much more than other structures. So the structure here, this tendon, the supraspinatus tendon, subscapularis tendon, these are the structures that get injured. And usually we spend about 2 days just talking about the shoulder when I do a workshop. And if you're over 40, it is frequently the glenohumeral joint that gets injured. And that might be this joint space between, of course, it's wrapped in the joint capsule, but that's the space where things really get in trouble. But the pain does not generally originate in the muscles. Often the muscles may be a factor, but they're not usually the cause of the pain. Now, in the low back and the neck, the most lasting pains in my experience are caused by damage to the ligaments, resulting in chronic adhesive scar tissue. Here in the neck, the supraspinous ligaments, the intertransverse ligaments, and the sacroiliac ligaments, etc. Sometimes the supraspinous ligaments are affected in the low back. Sometimes they're not. Sometimes it's the other ligaments. And it's frequently the sacroiliac ligaments or the sacrotuberous ligaments over here, or maybe the iliolumbar ligament on top. These are the main culprits when you have long-term neck pain, long-term lower back pain. Ligaments do not heal very quickly. This misconception that chronic muscle tension creates the pain in a major way was really a deeply held belief for me that lasted for the first, let's say, 14 years of my professional career. And what changed it for me is that I met and studied with Dr. James Syriacs. And when I learned how precisely you could assess each injury in the body, it literally blew my mind. I mean, it totally revolutionized my thinking. And I remember skeptically watching him assess one person after another and being stunned at what and how much I didn't know. That meant that I had to open myself up to the possibility that what I had learned was partially wrong. And what I thought I knew to be true could be wrong. And also what I'd taught and written about was wrong. And it was a very important moment in my life. Now, one that would change my perspective and my work for the rest of my career. The scientific method describes, setting up a hypothesis and then proving it or disproving it. And I had many hypotheses, but no real research proof behind a lot of the different things that I believed. And what Dr. Syriacs presented to me could be scientifically validated, and it was really hard to argue with. And believe me, I wanted to argue with it. And the hypothesis was that a particular structure, let's say the supraspinatus tendon that we are showing you here in the middle part of the screen, is injured, causing pain down the client's arm. Now, Dr. Syriacs proved it by doing a resisted test which produced the client's pain right there at that moment. Then he took out this needle that had included xylocaine, the stuff the dentist puts in your gums so you don't have pain, and he injected that tendon, and it numbed it, and the pain instantly disappeared. And he tested the patient again several minutes later after the xylocaine had taken its effect, and there was no pain whatsoever. And he did this throughout his entire, life. So it was very impressive to me. Although, I don't really believe things unless I see them for myself. And I spent the next 8 months studying alongside a physician friend of mine who had also taken the course with Syriacs. And we studied together, and we saw people for free for 3 days a week for months and months and months, assessing them and doing treatment that was very inexpensive to see that, see if this worked. And as this process unfolded, I realized that orthopedic medicine, the term that Dr. Syriacs had coined in the 1940s to describe non-surgical, soft tissue-oriented medicine, had provided me with the missing piece of the puzzle. And I realized that muscles did not account for the majority of chronic pain and injuries that people experienced. Rather, injured and inflamed ligaments, tendons, joints, bursars, etc., are responsible for the vast majority of chronic pain complaints. So to summarize, if you get a pain in the afternoon as you make an awkward movement or lift something a little bit heavy for you, and then you wake up the next morning or even the next week and it's gone, it's likely that you've suffered an injury to a muscle. Now, there are millions of muscle injuries. They happen all the time, but they heal very quickly with any kind of treatment or with no treatment. I used to say, if you lock the person in a closet for a week and it's a muscle, it's going to get better. If, however, you experience pain one day and it continues for months and months or years and years, it's much more likely that the cause of this ongoing kind of chronic pain is not because of damage to a muscle, but to a ligament, a tendon, a joint, or a bursar. Now, these structures heal very, very slowly and develop what we call adhesive, painful scar tissue as they heal, unless they heal perfectly, right, which they often don't. Now, unfortunately, because of the slow healing and constant reuse of that body part and the re-tearing of the scar tissue, the adhesions keep developing between the fibers, producing an ongoing chronic tearing adhesive scar tissue situation, as you see in this slide here. This is all those fibers stuck together in every which way. That's not going to be very useful. So knowledge about each of these structures is essential for effective assessment and treatment in our clients' pain problems. And that means the muscles, the tendons, the fascia, the ligaments, the bursars, the nerves, etc., etc. Certainly, a thorough understanding of muscle anatomy is also necessary, but not sufficient by itself. So I hope I've given you some food for thought on that particular misconception. Let's move on to number 2. Increased circulation is the major contribution a massage therapist makes toward healing injured tissues. Now, I believe that for a long time. So the healing of musculoskeletal injuries is affected by a wide variety of factors, from nutrition, kind of what you eat, to emotional stress, to body alignment and your exercise habits. Circulation is one factor, one key factor, and increased blood flow to injured tissues is often highlighted as the major benefit of massage. Now, massage therapy research has thus far not, I repeat, not been able to document that massage increases blood circulation through the body. Okay? A more important contribution that therapists can make toward healing of tissues is helping to eliminate adhesive scar tissue. And many practitioners are unaware of this benefit of a very specialized type of massage. Many therapists don't fully understand the process by which soft tissue injuries lead to chronic pain conditions and how the healing actually takes place. Now, when I began my career, I also thought that all I needed to do was, relax the muscles and increase the circulation, and the person would get better. And typically, chronic pain results when an injury heals improperly. With poorly formed adhesive scar tissue, that's what happens. Now, if I gave them a massage, they healed. Sometimes it was a muscle injury. And, and that's fine. But that's not usually the one that somebody comes in that they said they've had for 5 years. Now, in the healthy healing process, scar tissue serves as the biological glue that holds the torn fibers together in the proper alignment. And if I go back to this picture here, this is healing of scar tissue in the proper alignment. However, in many cases, the process goes wild, goes awry, and the scar tissue builds up in a jumbled mass of adhesions, forming a very weak structure of these adhesions that's very vulnerable to re-injury. And a vicious cycle begins where the tissue tears again and heals again, and each time causing more pain and creating more and more and more adhesive scar tissue. So breaking this cycle is the key to effective treatment. Existing adhesive scar tissue in the muscles, the tendons, and the ligaments can be broken up with the application of cross-fiber or friction therapy. And in more serious cases, sometimes manipulation combined with some cross-fiber work, or just injection therapy if it's been there forever and it's very, very deep inside the body. Sometimes you would injure something that's, let's say, 2 inches inside the neck or the knee, and you're not going to be able to do that with your hands. Now also, the work can, a different kind of work, with myofascial work, will work on the adhesions in the myofascial regions, the fascia that covers all these structures. And then to prevent the adhesions from continually forming in the body part, must be regularly moved through its full range of movement, during the healing process. So healing within a full range of motion is really crucial. And that's often something that's missed. Somebody, gets a treatment, and then they're not encouraged to move through. For instance, when you work the neck, you have to have the person rotate the neck in a very gentle, very simple way, 50 times, 2 or 3 times a day, to make sure the scar tissue doesn't come back. Another example, while a sprained ankle happens and is healing, it's got to be moved in all the different directions and not be kept still. And you don't want to move it so it's painful, but you move it within the painless range, if that's possible, which it usually is. Now, with a better understanding of how to eliminate adhesive scar tissue and prevent its reformation, massage therapists can help their clients to heal much more quickly and stay well in the long term. And so in summary, the major contribution a massage therapist or body worker or any good therapist can make can be a physical therapist, could be any type of body worker, is to not just increase the blood circulation, but to identify and eliminate the adhesive scar tissue that's causing all that pain. So misconception 3, working at the site of the pain yields the best results. Not necessarily true. The location of a client's pain is often really misleading. In many cases, pain is referred from the source of the injury to another part of the body, and sometimes really far away. Only certain areas of the body refer pain, and these include the shoulders, the neck, the thorax, the low back, the sacrum, and the hips, hip joints and the ligaments surrounding them. Okay? Now, some areas of the body don't refer pain at all, and primarily it's the distal areas, the distal joints, and that is the knee, the foot, the ankle, the elbow, the wrist, and the hand. These do not refer pain any appreciable distance. Where they say it hurts is usually where it is. Now, pain felt only in the arm is often caused by an injury to the shoulder. And pain felt at the medial border of the scapula. How many people here have ever had pain in their medial border of their scapula? Tell me. Write in your question box. Or how many people have clients who see people with that particular problem? This happens to millions of people, and people haven't got a clue as to what the heck is going on here. Medial scapular pain is something we'll cover in the workshop when I come to Australia. It's a ligament that's way, way far away from the scapula. Okay, and pain in the outer calf is often caused by micro tears in the gluteus medius muscle in the buttock. And an in-depth understanding of referred pain is crucial for pinpointing the exact location of the injury. I want you to keep in mind these 4 principles. Referred pain from soft tissue injuries is usually felt distally. Now that's the first principle. Out toward the periphery of the body. So for example, pain may be referred from the neck or the shoulder down the arm to the wrist, but not from the elbow or the wrist up to the neck. Doesn't go that way in orthopedic medicine. Second principle, pain doesn't refer from the right side of the body to the left side of the body, okay, in this system of thought. If a client experiences pain on the right and then it travels over to the left, what's happening? Why don't you type that in your question box? You tell me, what do you think is happening if they have pain in the right and then they have pain in the left? They say, oh, it traveled over there. What happened? That's right. They have 2 injuries, one on the right, one on the left. If you have an injury in the right, you compensate, and then you injure the other side. And they could also have a central problem, which somebody else said. They could have an injury right in the center of the ligament in the neck, and it could go down both sides. Okay, great. So principle 3, the distance pain refers is directly proportional to the severity of the injury. So a mild injury may refer pain to the bottom of the deltoid, let's say, while a severe injury can go all the way down to the wrist if it's in the shoulder, or into the hand if it's the neck. And this final principle, an injured structure will refer pain only to other structures within the same dermatome. Okay? Tissues that arose from the same segment in embryological development. Now, various structures, excuse me, let me take a drink of water here. It's 5 o'clock in the morning here, so it's a little different. Okay, so various structures within the same dermatome can cause similar referred pain patterns. For example, pain that's referred to the arm from the shoulder is usually in the C5 dermatome distribution. You can see that in the illustration over here. And it may be caused by damage to any one of the rotator cuff tendons. It can be caused by an injury to the shoulder joint. It can be caused by an injury to the bursa, many different things. Now, the parts of the shoulder that are in other dermatomes will cause different kinds of referred pain patterns. Like the AC joint is a C4, and it's going to hurt on top of the shoulder and maybe slightly into the chest or slightly into the upper back. Now, it's counterintuitive. It's really a counterintuitive thing to comprehend, especially if it's happening to you. I remember having a severe pain in my lateral calf, and even though I knew better, I could not really believe that it was coming from a tear in my gluteus medius. And only after my doctor friend had eliminated the pain for me by breaking up the scar tissue in the gluteus with some injections of xylocaine did I come to my senses and realize, that the client, in this case me, is often really a terrible judgment of what's happening. So, misconception 4. Whiplash is a precisely defined injury in the neck. So although many people refer to whiplash as a specific injury, it's really just an action, not a precise injury. Whiplash is defined as a sudden physical action of acceleration, deceleration force that causes damage to all kinds of structures. Now, these can include damage to the intervertebral discs, the nerves, the bones, the ligaments, the muscles, the zygapophyseal or facet joints, the fascia, and so forth. And research using high-speed cameras shows that the mechanism of the injury is generally forceful hyperextension of the neck, rapidly followed by hyperflexion of the neck. Now, this motion causes multiple tissue damage to the muscles, ligaments, and fascia, setting up the development of chronic adhesive scar tissue. Of course, you can also fracture your bone. You can damage a disc, but not usually. Whiplash usually occurs during a rear-end collision. The motion is generally posterior to anterior. but it can also occur laterally from side to side, like a side impact accident in a car. And when this occurs, the pain and damage is generally to the structures on the side of the neck if you got hit on the side, resulting primarily in pain on one side of the neck. Now, it also can occur in a head-on collision, and it doesn't have to be in a car. Whiplash was first noticed in train accidents almost a century ago, and it was called railway spine. Whiplash can also occur by colliding into another person, and this often happens during sports and events like football or basketball, or what we call soccer, what you call football, happens all the time. Now, whiplash will often be accompanied by a concussion when the head snaps back or forward and hits something. Now, this may result in many different symptoms, including a nasty headache that can go on for weeks, months, or even years. Now, in many cases of whiplash accidents, people recover kind of quickly without any symptoms at all. But other people continue to experience painful symptoms for years and years after the injury. I remember a high-functioning athletic young woman I saw about 3 years ago after being rear-ended when she was just sitting at a red stoplight. She had daily headaches, mostly in the occipital region, along with pain in the right scapula, down the arm, and occasional bouts of vertigo, dizziness, nausea. And right after the accident, she only had a headache. And after a week, she had pain in her neck and her arm. And by the end of the second week, the other symptoms followed and never abated. And what this is about is the scar tissue developing over several weeks, and it usually takes a couple of weeks after a whiplash injury to see what's really happened. So all this is to say, whiplash is not a specific injury. It's an action that causes many, 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 many injuries in the neck, most of which I cover when I do my neck workshop. So let's look at the structures that can be affected when there's a whiplash accident. Now, first, let's consider the muscles that are usually affected. Now, the occipital muscles of the neck and the deep and superficial ones are often injured. So here you've got your superficial occipital, and then way under here you've got your deep ones. The splenius cervicis, splenius capitis, muscles at the back as well. The sternocleido muscles usually get really strained and very sore. These are the ones, of course, you use to rotate your neck. Now then there's the ligaments in the cervical region. The supraspinous ligaments that connect the vertebrae, those in the back of your neck. So if you put your fingers at the back of your neck and you feel those bumps there, right on top of those ligaments, you've got the combination of the supraspinous ligaments and the ligamentum nuchae that are commingled, and they take a beating in a whiplash incident. Then we've got the interspinous ligaments, which are very deep, which are underneath these ligaments, way deep in between the vertebrae. Then we have the intertransverse ligaments over here on the side, which hold the transverse processes together. And of course, the fascia surrounding and covering all these muscles and ligaments is also affected. Then, of course, there are the discs that can be damaged and displaced. So they compress one or more of the nerves in the neck. Generally, it's C5, C6 that's affected, but it can be any of the nerves in the neck that are affected. However, the nerve thing, the pinched nerve, the disc, it doesn't happen in the vast majority of cases. Usually, it's the muscles initially that cause some discomfort, and the ligaments that get traumatized that are really long-lasting. As we talked about earlier, the muscle is going to heal relatively quickly because they're highly vascularized and enjoy a great deal of circulation. And this usually occurs within the first few weeks in the case of whiplash. And what gets left behind is the ligaments of the neck. And those are the things that don't heal, that cause people not to be able to turn their head, not be able to look up, not be able to look down and type or tie their shoelaces. More precisely, it's the supraspinous and intertransverse ligaments that give them the problems that go on for years and years and years and years and years. I don't know how many people you know in the world that don't have neck pain sometimes, that don't wake up in the morning with neck pain, can't turn their head. In my country, it's like probably 1 in every 3 people in the United States about 100 million people. Not sure what it is in your country, but many, many people have neck pain. And what they do, they choose not to turn their head. They'll turn their body. They won't look up. They'll lean back. And of course, if there's trauma to the brain through a concussion, that can take quite a while to resolve. And of course, the person should see a physician to see if there's any kind of major damage. Now, in the example that I gave before of the young athletic woman I saw 3 years after the accident, the anterior neck pain was from the muscles, and they healed quickly. And the ongoing neck, arm, and scapular pain, came from the ligamentous scar tissue, which usually begins to appear in a few weeks after the accident. And the damage from the concussion, can last a long, long time, and did for her. In this case, I assessed her, and I have found that her cranial rhythm was incredibly weak and very uneven from right to left for those of you who do craniosacral work. Her supraspinous ligaments at the back of her cervical spine were severely damaged, especially C7, C6, C5, as well as those at the occipital protuberance up at C1, C2, and C3. And the upper segments, the upper ligaments refer pain to the back of the head, and that's why she experienced such a headache for quite a while. And the lower ligaments, they caused neck and arm pain. So I found transverse ligaments damaged at C5, 6, and 7, which caused the lateral neck and the medial border, pain down to the scapula and also down the arm. And also her fascial coverings had a lot of pain-producing problems, and we had to work on that. So the concussion, was not something that I could deal with. So, of course, I referred her to somebody else, and then who I referred to was a craniosacral osteopath who successfully restored her rhythm and the distortions in her cranial rhythm, and that took several months to take care of. And combined with treatment to the fascia that I did and the ligaments, she was able to get her life back. So let me stop right here for a minute, and I know I didn't say I was going to do this, but Geoff, why don't we see if there's any questions at this moment about anything I've just said. So if you've got a question about anything I've said so far, so we don't get too much information behind us, maybe I was exceedingly clear and you have no questions, but I'm going to give you a minute to see if you've got any questions, and then I'll continue. So give it a second, Geoff, and then ask me, and come on in. So what do you see there, Geoff?
There's one that came in a little bit earlier that related to how can you tell the difference between good scar tissue and adhesive scarring or adhesive scar tissue?
Great question. So there's a whole series of tests, and in the neck there are 40 different tests that you learn to do. And if you, for instance, if you do passive rotation, there's going to be pain. Or passive extension, there's going to be pain. There should be absolutely no pain on passive movements to the neck. And if you have good scar tissue, there's no pain. Next question. Is there anything else that came up? Somebody asked here if I'm coming to Melbourne. Well, if I have a success in Sydney, maybe Geoff will take me to Melbourne. Another person's asking, do I inject the structures to confirm the diagnosis? This is what Syriacs did for years. No, and I'm not a physician. I'm a PhD in sports medicine, so I don't do injections. So I don't do that. But I've had a huge amount of experience and trained people to palpate the structures. When you touch the ligamentous structures in the neck, there should be absolutely no pain. And if there is pain in many or any of the ligaments, there's a lot of work to do. And the ligaments can heal. Somebody asked about how long does it take to heal. Ligaments can heal if it's very minor. I'll give you an example. I had a couple. Maybe I'll give this example later. I'll do it now. Had a couple that had a whiplash accident. The husband healed in 2 treatments, and the wife took 6 months and about 20 treatments to heal. So it just depends on what you bring to the table. How, what's your body like? How healthy are you? How well do you eat? How well do you sleep? Do you exercise, et cetera, et cetera? So that's another issue. How long do you cross fiber friction? Well, it depends on how many ligaments. Usually if it's one, you might do 10 minutes with a break in the middle. And if it's 10 ligaments, you probably do a minute at a time, keep moving between them. Okay, I'm going to take the rest of the questions a little bit later. I just wanted to give people a moment if they were frustrated because they couldn't ask something. So let's go on to misconception 5. Poor body alignment is often a primary and direct cause of pain in the body. So this is a common misconception in the massage and bodywork field and in lots of the healthcare world. And I frequently hear practitioners in my courses say, the low back, the hip, the knee, the ankle are misaligned, and that's what's causing the client's pain. Now, in my experience, the direct cause of pain is never poor body alignment. What causes pain is inflammation, tearing, swelling, rupture of some of the damaged tissue in the body. Now, following the damage, the scar tissue begins to form, usually in a random pattern that's usually weak and unsustainable, causing the pain. And when force is applied, painful re-tearing keeps occurring, and you get more and more scar tissue. Now, poor body alignment is also very important, but it's the precursor to the injury. It's what we call an indirect cause that set the body up to get injured. Injured really means you have something that's broken, torn, swollen, that's causing your pain at the moment. Now, of course, you want to work on both, but the alignment is not the cause of the pain at the moment. It sets you up for it. For example, there may be a misalignment in the pelvis as a result of tightening one of your psoas muscles, causing one leg to become functionally shorter than the other leg. Now, that may occur as a result of a lopsided walk. That is a result of one leg being shortened, and it causes a torque on the sacrum, a shearing stress on the sacroiliac ligaments and the fascia, and if uncorrected, some tearing of some of the sacroiliac fibers and fascia will occur, and that becomes the direct cause of the pain. Another example would be if a person walks with their feet turned out, let's say 10 or 15 degrees, and there's going to be strain on the medial thigh, the medial knee, the lower leg, and the ankle, okay, depending on the amount of the turn. So this sets the leg up for multiple injuries, like a sprained ankle on the medial collateral ligaments that holds the tibia and the femur. The ligaments also that hold the tibia and the femur together, the medial knee, for instance, the medial collateral ligament is going to be affected, the adductor muscles, and also the ankle. And you could get here we're showing pronation, so all these deltoid ligaments, they're called, on the medial side, and then you're going to get weak on the outside, and you may hurt yourself on the outside because you can't sustain it. And if the feet are turned in, you're going to be straining the lateral side. So these alignment issues are the indirect causes of the pain, and when you sprain your ankle, you've got a direct cause of the pain. Misconception 6. No form of bodywork can help reverse the symptoms of neurological diseases. And I believed this very, very strongly for a huge portion of my career, and I was really happy when I was proved wrong, because I tried treating people with all sorts of things. And yeah, they felt better for a night, they might sleep the night through, but it wouldn't make any major changes. And when I discovered what I'm going to talk about next, it made a huge difference. So I never thought that, anything could really reverse or stop a neurological disease, except about 6 or 7 years ago, I discovered and found active isolated stretching and strengthening developed by a man named Aaron Mattis, who's a kinesiologist in Florida. And he helped people with neurological diseases, at least what he said, to function more fully than ever. And, my mind went through a major belief system change, but only after I did it, not after I heard it. Okay. Now, it's one thing to have a theoretical understanding of a technique like active isolated stretching, which is abbreviated AIS. Everybody has a theory about why things happen. It's quite another thing to see it in action with real people who are suffering from progressive degenerative diseases or spinal cord injuries and things like that. I don't believe anything ever until it's proven to me. And when I first heard that it could help with Parkinson's and multiple sclerosis and polio and other neurological conditions, I was very skeptical. I didn't know that I was going to be dramatically changing my mind. And only after seeing incredible improvements in my own clients with these conditions did I fully comprehend and accept that this was even possible, because I'm a pretty scientifically oriented person. Now, the theory is that you can create new neurological pathways with the repeated techniques of AIS. And as yet, there's really no scientific proof of that. I've only seen it work on lots of people, and I get really excited when I get a client who has Parkinson's or MS, because I know it's going to be quite a journey. And actually, the first client that I worked with was a woman with MS who had been in a wheelchair for many years. She lived right near me, so I knew her. She couldn't even turn over in bed. She couldn't crawl, to reach something. And after working on her as an experiment, I said, hey, I have no idea if this is going to help you. For a month, she began to be able to stand, turn over in bed, take a few steps with a walker, something she hadn't been able to do in years. And after another month of treatment, she began to be able to crawl, turn over in bed. Now, these may sound like small things, but these were huge reversals of her deterioration for her. And frankly, it actually blew me totally away. And the second case I had was a woman who had Parkinson's disease. She was a college professor at a big university here in Boston, whose symptoms had begun 5 years ago. And I began to treat her with hour-long AIS sessions twice a week. And she began to feel increasingly looser, stronger, more flexible, and less rigid, which is one of the symptoms. And it took a few months, but within about 2 or 3 months, there began to be drastic changes in her symptoms. Previously, her right foot would always drag when she walked. Now it never did, even when on the days when she was on stress, when things got worse. For several years, she hadn't been able to brush her hair with her right hand. Now she just picked up her brush and just started doing it one day. She couldn't write. For 4 years, she was a teacher. She could not write on the blackboard. And N's and M's get very tiny when people have MS. She could now write. And she was totally thrilled, and it totally changed her life around. Now, practitioners in all modalities are subject to certain biases in the way they approach assessment and treatment. And massage therapists are, no exception. So we have to keep our mind, open in terms of, how things will change or not change. So let's see, where is number 7 here? Number 7, pain. Most pain down the arm comes from a pinched nerve in the neck. So this will be our last little misconception, then you can ask some questions if you would like. So pain down the arm can be caused by all sorts of things, a number of different kinds of injuries. The most common cause of pain down the arm is actually a shoulder injury. The neck, of course, is next. And there are a number of different shoulder injuries that can cause that pain. Sometimes severe pain can be referred, from the deltoid area all the way down to the wrist. Shoulder injuries don't go into the hand because the dermatome doesn't go into the hand. For example, the subscapularis injury, which is at the front of the shoulder, right, where is it? Right over here. That can cause a pain that can go all the way down your arm, particularly down the triceps region. So the pain is in the front of your shoulder, like over here, let's say in the front of your shoulder, but you feel it in the back of the arm. It's kind of counterintuitive. Supraspinatus or infraspinatus can be referred down the front or back of the arm all the way to the wrist, this one and this one here. And if you have chronic or acute bursitis or a frozen shoulder, you can have pain down the arm too. So all these different things in the shoulder, like I've mentioned, 8 or 10 different things can cause pain down the arm. So you can also have referred pain from the arm that comes from the neck. So if you have an injury in the neck and it goes down the arm, it can come a little bit, and it can actually go all the way to the hand. And it can be very, very severe. So, we've named many different injuries, and it could be that you have an injury to all of those different ligaments I pointed out. You've got like 18, 19 different ligaments in the neck that can cause pain down the arm. So you've got 20 different things that cause pain that comes down the arm. So a client could also have an elbow injury that causes pain in the lower arm, and there's no referred pain in the elbow. So when the client experiences pain in the lower arm, it means they have multiple injuries simultaneously. For example, if we looked at tennis elbow, you could have pain in all these different 5 areas, down in the muscle, up at this attachment of the longus, the attachment of the brevis, and the tendon body, the muscular tendinous junction of the extensor carpi radialis, brevis, and longus. So all of these different things can cause a pain, down the arm. So let's get now to the pinched nerve thing here. I don't want to keep you too long here. I went on and on here. So let's talk about a pinched nerve in the neck. So in order for the nerve to be compressed, something has to be pressing on it. Now, if this occurs, it's usually posterior lateral protrusion of an intervertebral disc. Now, although this does occur, it's not as common as is often thought. The ligament injuries in the neck, which refer pain down the arm, occur with incredibly greater frequency than discs pressing on nerves. So when most people think they have a pinched nerve that's causing the pain down, I've just given you 20 other things that could cause a pain down the arm, and there are whole bunches of them in the neck and the ligaments. Now, if the pain is severe, it can go in various directions. It can travel down the arm, it can go to the hand, the fingers, it could go to the chest. In fact, this is one of the ways you tell the difference between a pain that's referred from the shoulder and a pain that's referring from the neck. A pain going down to the hand can't be coming from the shoulder. It has to be coming from the neck, or it's a pain that's just happening in your hand. Both ligaments and discs in the neck refer pain to the hand. And if it's a shoulder injury, of course, it doesn't go that far. And many of the ligaments in the neck cause pain down the arm. And some of the ligaments actually will cause you to have a pain in the head. All of these different referred pain patterns come from various ligaments in the neck. So pinched nerve in the neck happens, but it is not the most common thing that gives you a pain in your arm, going down your neck, going down your shoulder blade, etc. That's not the most common reason. Now, practitioners, in all modalities, again, I said before, have their prejudices. And in 1979, when I studied orthopedic medicine, I had really limited ways of thinking about it because I thought it's all muscles. And I've used these principles of orthopedic massage, orthopedic medicine to demonstrate, these fallacies to myself and to many other students. And I hope you find this information useful in expanding your knowledge and providing the best care for your clients. And if you want to ask me some questions now, I'm open. So, Geoff, come on back in, and whatever questions people have, I'll be happy to answer.
Oh, there's a couple on ligaments here. One of them is, will you be teaching how to distinguish between these ligaments? And along the same line, will you teach palpation of the ligaments in the workshop in March?
Yeah, we do that. We do that in the workshop. That's what a lot of the workshop is about. Some of the workshop is about doing all the testing so you can figure out what's going on, and the other part of the workshop is how do you find these ligaments? How do you treat these ligaments? You can put your finger on the lateral edge of the C5 ligament because that could be the problem that's causing pain into the jaw, into the upper back, etc. So that's what the whole workshop is about. It's very hands-on. We talk about some theory, but it's a lot of practice, a lot of learning really how to do it. I like people to leave my workshops knowing how to do it, not thinking that I know a lot, but that they know a lot and they can really do it.
Okay. And do you use your hands only, or do you use tools as well in your treatments?
I just use my hands. I mean, occasionally I might use an osteopathic Fulford machine, a kind of vibrating machine, pulsating machine, but not usually on the neck. In the neck, you usually use your hands.
And Chris, is active isolated stretching the same as PNF stretching?
No, it's absolutely different, totally different technique. And someone also I see asked, does it work with stroke victims? And it does. It works fantastic stuff with stroke victims. It's a very different technique. You do these stretches in Aaron Mattis thought up 175 stretches. Now, I've barely, before that, ever seen 10 that I liked, but there are 175 stretches that I teach. About half of them for the upper body, which we're going to do the first time in Australia, for the neck, the shoulder, the upper arm, the lower arm, the hands, the fingers, the joints. And it really rewires the person's brain. And what we've learned from brain research is that you can use neighbor structures in the brain to rewire and to relearn how to do things. And it's pretty amazing what it does. Next question.
There was a couple of questions that were actually fielded through the website, and that was related to the half day that you do. There's a 2.5 day workshop, and there's a half day where you just do like a clinic. I know a few people were very interested in hearing more about how that worked too.
Okay, so we spend the first day learning how to test all these injuries. It takes hours and hours and hours, to learn how to test everything, the ligaments, the discs, et cetera, the muscles. And so you learn first about the history, you learn about the testing, you learn about the treatment, you learn all those things, but then you've got to really apply it. So in my, last, 40-some years of teaching, I developed a clinic where you invite your clients, and you just put out signs in the street. You get 10, 20 different clients, and you work in little small teams toward the end of the workshop. And the clients come in and you work in groups of 2, 3, 4, 5 people, and you take a history, you do all the tests, and you figure out what's wrong with that person. And at the end of those couple of hours that we do, I assess in front of the entire group those that are more difficult. If there was a complicated case that had multiple, like if they had shoulder and neck, that might have confused you, and I verify with you, and I'm standing there, and if you ever need me, you call me over if you're having a problem. But by the time we get to the clinic, people really know what they're doing, and it really puts all the information together. You take the history, you do the test, you do the palpation, you find it, and the overwhelming majority of people have ligament injuries that no one ever knew were there. And you touch them, and you touch them with a very slight amount of pressure, and they have enormous amount of discomfort. And sometimes the pain actually refers down their arm when you touch their ligament or down their shoulder blade. So that's how the clinic works.
Okay, fantastic.
Next question. Somebody else is asking, am I going to teach the AIS techniques in the workshops? Yes, we're going to have 2 separate workshops, one for the assessment and treatment of pain and injuries in the neck, and the other for the AIS work that goes along with it for the neck and also the shoulder and the hand.
Okay, a lot of these, they've kind of answered these, distinguishing disc problems from ligament problems and the like. What do you find the most affected structures are when a person has a whiplash?
What do I find the structures that are injured, you're saying?
The most effective structures when a person has whiplash. So
most affected. Okay, I thought you said effective. Okay, affected. Okay, the greatest curve in the neck happens at C5, and that's the most vulnerable to injury. So that one usually gets a lot of scar tissue and sprain, a lot of micro tearing. So C5 is a very, very common structure. Also, the suboccipital muscles can get scarred, and also the intertransverse, 7th intertransverse ligament. Those are the ones that are really nasty, that hang on forever, that cause the most problems. But they could have all 18 ligaments sprained, and you got to treat them all. And when you do, they get better.
Mm-hmm.
And also to mention while we're here that this www.benbenjamin.com.au is where you register if you want to look at the workshop and what we're going to teach. And if you want to register, you can do that or call Geoff. So, other questions?
How do you treat bursitis?
You send them to someone else, because you can't treat bursitis with your hands. It's inflammation in the bursa, and either they have to wait, and if a person hates injections, they can do some bee venom injections. Bee venom has the natural properties of corticosteroids that are produced chemically, and an anti-inflammatory injection will usually get rid of it instantly. I had a client, not a client actually, a friend's girlfriend, who had pain in her shoulders from bursitis for 5 years. And she couldn't lift her arm above 90 degrees for 5 years. And she ran a frame shop, and that was tough. And I don't ever do assessments on my friends just, seeing their pain, and I don't volunteer. I only work with people when they ask me. And a mutual friend said, "Why don't you go to Ben, because he could probably help." He said, "No, I've gone to the doctor, got arthritis, nothing can help." Yeah, I'll go anyway. So it turned out that she had chronic bursitis in both shoulders, which just gives mild pain generally, but only if you lift your arm to 90 degrees. And one injection in each shoulder was completely gone in 2 days, completely changed her life forever. So got to know how to assess what's going on. Very difficult to treat something if you don't know what it is. And most people just do a shotgun approach. When I started, I did everything I knew. Like somebody had a sprained ankle, I'd work for an hour and a half, do everything I knew, and by luck, they would get better. Later, I learned that all I had to do was use one finger on 1 or 2 ligaments, and in 10 minutes, the treatment would be over. So, again, the more knowledge you have, the better, the more exciting your work can be. It's great to be a detective and be able to figure out what you can treat and what you can't, and refer people. I've often seen people once, referred them to somebody else who could help them, and they would refer me people for years and years because I was the only person who knew what was wrong with them. Any other question?
There's probably a group one around posture. Probably summarising those, that would be, if someone has bad alignment, what would you suggest in terms of this work?
Well, first, if they had pain, I would get rid of the pain first. And as I was getting rid of the pain, I would probably be doing some myofascial work to get rid of the myofascial distortion. I'm also a fitness trainer, so I'd take them down to the gym downstairs or send them to somebody else if I didn't have time, and put a whole fitness program together because they had a head forward, or they had a rounded shoulders there. They'd ever use their back muscles, and I would be giving them exercise programs to do 3 or 4 times a week, and telling them if they want to not be back in my office and they want to be strong and in a good alignment, etc., I would tell them to do that. Another thing I might do if they had bad alignment is I might send them to an Alexander technique practitioner or a Feldenkrais practitioner. Do you guys have those kinds of practitioners down there?
Yes, we certainly do.
Okay, actually, Alexander technique was developed by an Australian, I think, or an Englishman. I'm not sure which. But those techniques, I would have a whole referral network of those kinds of practitioners. Mm-hmm. Somebody also asked, can you actually touch the intertransverse ligaments? Yes, you absolutely can. You just have to learn how to do it, and they cause a phenomenal amount of pain, and can be helped quite easily. And somebody else asked how frequently I see somebody for AIS. I might do a session with them twice a week for a while, and then once a week as they're getting better, or if they're good at homework. If they're good at doing stuff on their own, then I'll work with them for a few months, and then I'll have them do it mostly on their own and see them once in a while, especially if it's a financial or a traveling or time problem. Some people just love to, I love to get an AIS session every week. I go and get one every week, 2 if I can, because I think it does fantastic things for my body. I am more flexible now than I ever was in my entire life after doing AIS for 3 months, having it done on my body. Any other question that we didn't cover?
Let's see.
I see one here that says, how long do my consultations last? Well, that depends on what the person has. If somebody comes in with like one injury, it might take a half an hour. And if they come in with like pain in the neck, the back, the knee, the foot, the ankle, the wrist, the shoulder, it might take an hour. I just have sort of one fee because they're paying for my expertise, not my time necessarily in an assessment. And it's probably the most important time that I spend with them. The most important appointment is to figure out what is going on. I can't tell you the number of people that have had, $10,000 worth of tests when we figured out what it was like in 25 minutes. And all those tests were maybe important to do, but nobody figured them out because no one ever touched the patient. No one ever did these hands-on testing procedures that Syriacs figured out.
There's one from Tracy there. In your experience, what consideration do you give to psychology of chronic pain in your type of treatments?
Well, the most dangerous time for a client is when they're getting better, especially for people who are a little bit depressed and need to exercise to feel not so depressed because that produces some dopamine. And sometimes people have psychological issues, and maybe all of us have some psychological issues, but sometimes it really affects our body and our pain. And sometimes I will refer somebody to a psychotherapist. For example, I had a client, whenever she got a call from her mother, within 30 seconds, her back was in spasm. I mean, literally every time. And this woman really needed some therapy. She had a lot of muscle tension. She had a lot of other issues, but she had a big emotional issue. And, and she asked me for a book. I gave her a book to read, and then she asked me about it. And then she went to therapy, and her whole life changed. So I also am very cognizant of people who've been the victims of physical or sexual abuse. And I wrote a whole book called The Ethics of Touch, and train people in how to work with people who've been traumatized, who have PTSD from whatever, whether it's war or abuse of some kind. And those individuals, I won't work with an individual like that unless they're going to a therapist at the same time to take care of the issues that get unraveled. When I work on their neck or their head or their arm or their shoulder, there may be memories or things that come up, and I want to practice in my scope of practice, be responsible, and have those people be seeing a therapist simultaneously with seeing me so they could take care of those issues. So I think it's very important in some cases, and in other cases the person is not interested. They just, they may need it, but they may not be interested. I'm not going to push it. I'm just going to say, let's get rid of your pain. And if they inquire about something around their psychology, or they ask me why they have these pains or these headaches, I might say, well, sometimes there's emotional issues when people hold back what they want to say, hold back their feelings, when they're feeling sad, when they're feeling angry, and they don't know what to do. It accumulates, and they can get a headache. I have a whole webinar series on headaches, which are really about energy and emotion, which is the cause of most chronic headaches, in my opinion. So we should probably come to a close here, unless there's any pressing question. What do you think there, Geoff? Let me go.
Yeah, the AIS techniques used following your hands-on treatment or in place of?
Okay, then let's make that the last question. So okay. Let's say somebody's coming in and they're in a lot of pain. I'd start out with a hands-on treatment. Now, after, let's say, a month of treating them a couple times a week, their neck is getting much better. Now, when they come in, I'll start with them with the AIS work in the neck, and then I'll put them on the table. So you can do it really in any order. And some people are only coming for their fitness. I've got people coming, they're not very flexible, they're not very strong, they're not got good balance. They only come for fitness, and I only do AIS. Some people come for an injury, and they only want me to do that. But I'll usually do both with a person who has an injury and just fitness with people who want to be more fit. So let me just show you there are many, many webinars available online on my website, benbenjamin.com. I have series on all sorts of things. If you're in Melbourne and you want to see what I'm like more, you can take one of these. Tom Myers has several webinars, Whitney Lowe, one on pregnancy, and some wonderful webinars on cancer and various other conditions by Tracy Walton. You can read all about them on the site if you're interested. So let me now turn it over to you, Geoff, to say what you're going to say about my coming to Australia, if you'd like.
Sure, there's fantastic questions there. Hopefully we'll see these people at the workshops. But just before I say thank you to you, I know that there's a number of people already registered for the workshops in Sydney, which is in about 40 days, so it's about 6 weeks away. So we're really extremely excited to have had a glimpse into the depth of knowledge of what we'll be learning, and can't wait to nail these assessment techniques. So I'm sure a few people are going to start dropping off the webinar now, and I'll bet that they're heading straight over to benbenjamin.com.au website. You're still able to register now, and you'll still be eligible for a $100 discount that's currently available. So if you'd like, hang up now and jump onto your computer and go to the website and register there. So with that, I'd just like to wrap up the webinar by thanking everyone who attended, and those that couldn't attend, tough luck. And also a very special thanks to Dr. Ben Benjamin for preparing and presenting this fascinating webinar. So if you can all, wherever you are, in your lounge room or bedroom or office, just jump up and clap and cheer. That would be fantastic. So thank you very much, Ben, and we look forward to seeing you in March.
Great, and also maybe to tell people that they can share this webinar with other people. They'll have access to a copy of it, and they can share it with any friends that they would like to.
And there's lots of clapping on the questions now. Clap, clap, clap.
Well, thank you very much. It was delightful to get up and work with you, and I look forward to meeting many of you when I come to Australia.
Thank you for getting up so early. We really appreciate
It's
it,
fine.
friend.
No
Thank you.
problem. Bye-bye.
Right, thank you.